Now when we are talking about N, that is nodal status, there are multiple lymph node stations, okay, and there is something called as primary echelon nodes. So each subsite has a predominant nodal station where it drains. In oral cavity, level 1B, 1A and level 2 are the primary echelon nodes. So what does that mean? That the chances of having a lymph nodal disease in level 1 and 2 is higher in oral cavity cancers. In oropharynx and larynx, what happens is it is more of level 2 and 3, okay. Then level 5 will be nasopharynx. So for this session, all you want to know is in oral cavity, level 1 is the predominant primary echelon node, okay. So there are sometimes something called as sentinel node biopsies which are done, where you find out where the lesion is primarily draining into and you remove only those lymph nodes. So now you have level 1A, okay. Level 1A is basically between the anterior belly of digastric, hyoid bone and mandible, okay. So these are the two anterior belly of digastric. So this is level 1A, okay. It is called as your submental triangle. Then you have level 1B. Level 1B will be between your anterior belly of digastric, posterior belly of digastric, okay, and mandible. So this is your 1B. It is called as submandibular triangle. These you are all very well aware from your anatomy classes. Then we have level 2, which is divided into A and B. It is basically based on your spinal accessory nerve. So anything which comes anterosuperior is 2A and posterior-inferior is 2B, okay. Then you have level 3. Level 3 is not further subdivided. Then you have level 4 and level 5. So these are important with two perspectives. One is where does the primary tumor drain, and it helps us in deciding what type of neck dissection is required, okay. So once we know what is the T and what is the N stage and of course M, we can finally decide on the final staging, and this helps us in deciding further treatment and explaining prognosis, okay. So stage 1 is basically T1 N0 M0, stage 2 is T2 N0 N0, stage 3 will be either T1 T2 T3 N1 or it is T3 N0, that becomes stage 3. Then stage 4 is either it is any size of the tumor but no nodal involvement, that also is 4, or you have, if it is a T4A but no nodal involvement, it is still a stage 4 disease, or if it is with nodal involvement, irrespective of the tumor size, but if it is N2, then it becomes stage 4A. Stage 4B will be T4B. So as if it is T4B and any N size, it is still a stage 4B disease, or it is any T with an N3 node. Again it becomes stage 4B. And 4C is your T size doesn't matter, your N doesn't matter. If metastasis is present, then it is stage 4C. Okay. So this was about staging. Now let's talk about pathology of cancer. So there are few features, okay, basically histopathological features. Okay. Once we remove the tumor and send it for HPE, they give you few parameters. Okay. These help us in staging and of course further treatment. Okay. So we will talk about a few things. So if a patient comes to you with a pathology report, what are the things which you would look for? Like I said, most of the oral cavity cancers are squamous cell carcinoma. Okay, so we will be talking pathology with respect to squamous cell carcinoma. In squamous cell carcinoma, most common is conventional type, and then of course, we have other less common types which can be papillary, adenosquamous, acantholytic, baseloid, spindle cell, verrucous, and carcinoma cuniculatum. Okay. So conventional SCC is most common. SCC as it is the most common kind of cancer of the oral cavity. In that, the conventional squamous cell carcinoma is the most common. We have few other less common subsites. Next is grade. So based on the grade of differentiation, you have whether it is well differentiated, whether it is moderately differentiated or poorly differentiated. So if you can remember your general pathology, the more the tumor resembles its native or normal squamous epithelium, it is well differentiated. The farther away it is from its native cell, it becomes poorly differentiated. Okay. So that is one part, that is grade of the tumor. Okay. So grade you have well, moderate and poorly. Okay. Then pattern of invasion. This pattern of invasion gives us an idea whether this tumor has higher chances of recurrence. Okay. So you have pattern of invasion. So pattern of invasion you have 5 types. Okay. So when you have 1, 2, 3, it is less aggressive. When you have 4 and 5, the tumor is more aggressive. So this becomes one important point in counseling the patient. If the patient has a pattern of invasion 4 or 5, then you can safely tell that this tumor is more aggressive and hence the chances of it coming back are more. Okay. Tumor thickness and depth of invasion. As I had mentioned earlier, tumor thickness is maximum dimension from the tumor surface to the deepest point of invasion. Okay. So and then depth of invasion is from the basement membrane. So you have epithelium, okay, then you have basement membrane, then you have stroma. Okay. So if you have a tumor which is like this, okay, from surface of the tumor, what you measure will be tumor thickness. But what you are measuring from the basement membrane to the deepest point of tumor invasion, that is called depth of invasion. Okay. Like I said, it has importance in prognosis. Perineural invasion is basically involvement of the adjacent nerves. It is either smaller unnamed nerves or bigger named nerves. Perineural invasion is one which you can see and it has more prognostic implication in adenoid cystic carcinoma. Okay, again it's a biological marker for telling us the aggressiveness of the tumor. So, perineural invasion is that. Then you have lymphovascular invasion, basically presence of tumor cells within a vessel, be it artery, vein or lymphatic channels.